So the purpose of CMS's advance notice is not to codify any changes, but rather to announce any possible changes and gather feedback from the industry. It's the big picture of where star ratings is headed. So today, I'll be sharing with you one, what we know for sure about the upcoming years, two, what CMS has proposed in the advance notice, and then three, what is the big picture of where star ratings is headed? My analysis of the advance notice and what it says about where stars is heading. And then we'll wrap up with some key takeaways for plans to consider. All right, so the first thing that we'll do is review codified and proposed changes. I'm going to go through 1 year at a time, starting with measurement year 2025. Now, this is the proactive year that is in progress right now, just started in January. So everything that we know about this measurement year is codified. There's nothing in the in the advance notice that could affect this measurement year. You'll notice that there are checkboxes in front of all of these items because they are codified. As we move to the following years, you'll see that some of those boxes are not checked to indicate that those are just proposed changes. So starting with the measures that are removed for 2025, the first one is the Care for Older Adults Pain Assessment Measure. NCQA has finalized the retirement of this measure, so CMS will follow suit. MedRec post-discharge has been that funny standalone measure, but also part of the TRC measure for quite a few years now. So the removal of the standalone MRP measure is now finalized. MedRec post-discharge will still be a part of TRC as it is today. It's just the standalone piece that is now removed. Moving on to the items that are added, we saw a Care for Older Adults Functional Status Assessment return after being gone for a few years. That returns at a 1x weight. There's the new Part D measure, concurrent use of opioids and benzodiazepines. That is is joining us as a 1x weight, as well as the other Part D pharmacy measure, polypharmacy, use of anticholinergic medications in older adults. I'm sure we've all been talking about the Health Equity Index, not just in our webinars, but also at work and perhaps over the dinner table. It is definitely a frequent topic of conversation for me and the folks that I work with. So the Health Equity Index is replacing the reward factor this year. The reward factor comes out, but the health equity index replaces it at that same 0.04 stars towards your overall star rating of your contract. And it measures the care of members with social risk factors, including low income subsidy, dual eligibility, and disability. My key takeaway here is for plans to make sure that all of their members with social risk factors are identified. We've heard across the industry that many plans don't have all of their low income subsidy members flagged appropriately, and that could be counting against you. Often these members require extra work, and so if you don't have them flagged appropriately, they can't increase your health equity index scores. And finally, the changed items for measurement year 2025. Colorectal cancer screening went through a substantive measure change. The age range is now expanded to include ages 45 to 49. Statin therapy for patients with cardiovascular disease now has a statin intolerance exclusion, so you could see the denominator go down slightly, but that's not expected to be a substantive change. Last year, we saw the two HOS measures, improving and maintaining physical or mental health. Those measures came back at a 1x weight. In measurement year 25, they increased to a 3x weight. And finally, CDC eye exam, the hybrid reporting option has been removed to follow suit with NCQA. This measure can only be reported administratively. Now, that is not considered to be a substantive change, though. So we don't see eye exam removed from the program or added back in again. It's just a change in how the measure is reported. All right, now let's move on to measurement year 2026, also known as STAR year 2028. Again, notice that there are some checked items, but also unchecked items in the bullets there. The unchecked items are the items that are just proposed at this time. So we know that the non-risk adjusted medication adherence measures are going to be removed next year, and they're going to be replaced with the risk adjusted med adherence measures. The measures themselves are calculated the same way based off the same population and the same needed proportion of days covered. The only difference in those is that the members themselves will now be risk adjusted to increase or decrease their weight based on their sociodemographic factors. Statin therapy for patients with cardiovascular disease will be removed. This proposed change is dependent on NCQA. NCQA is considering making some substantive measure changes, including removal of the existing sex-specific age bands, increasing the upper age limit, and moving the measure to ECDS. Because this is a substantive change that is expected, this new retooled measure would have to go through the process of rulemaking and being on the display page for at least 2 years before it could become part of the STAR ratings program. CMS also indicated that they intend to remove the guardrails for non-CAPS measures. So this is a proposal that was first proposed back in April of 29, guardrails were first codified back in April of 2019, and I think it was 2022 when they first proposed removing those guardrails. So this has been an item that's been on the docket for quite some time. Guardrails were first introduced with the intent of improving the predictability and stability of cut points. But as we all know, Tukey outlier deletion was also implemented with that same kind of thought in mind, right? Remove the extreme outliers, and so you can reduce the fluctuation of cut points from year to year. Now that Tukey outlier deletion is in place, CMS is saying that those guardrails are no longer needed, so that they can be removed. By removing the cut points, it would allow cut points to adjust up and down appropriately for any unanticipated changes in the performance of the industry. So of all of the changes for 2026, I would say that this one is the most likely to occur. You might want to start thinking about what effect that might have on your plans and the predicted cut points that you set for yourself. As I mentioned, risk-adjusted med adherence measures, that's codified already, and those measures will be joining us as a 1X weight in 2026. The other proposed addition was the initiation and engagement of substance use disorder treatment. Now, as you know, these are two different numerators in the same measure. CMS proposed that these two measures are averaged together and counted as a 1X weight total. So if you're monitoring the STAR ratings program at your plan, just like TRC, this measure will have that additional math that's needed to take the average of the two. Your plan does have to have rates in both of those measures in order to produce the average and count towards your overall score. Initial opioid prescribing for long duration. This one has been tossed around for more than one cycle now as well. It was deferred in the previous notice, but it looks like this one is likely to be added to the program starting with measurement year 2026 as well. Okay, let's move on to measurement year 2027 at this point. Now, as you notice, as we're moving through the years, there's less that's known for sure and more that's just proposed. We don't have as many definites, but at a high level, I want to give you an idea of the changes that are proposed so that you can start to get the bigger picture of where the STAR ratings program is headed. So we do know that the risk-adjusted measures, because they're outcome measures, they will increase from a 1X weight to a 3X weight. That is the only thing that we know for sure. Also, a proposed change is the improvement measure hold harmless policy. This was originally proposed in December of 2022, and it only would apply to five-star plans. I am going to read this directly because I think they did a great job of summarizing, and I don't want to get it wrong. CMS states, we believe that the hold harmless provision for the highest rating is not needed for 4 and 4.5 star contracts because they still have the potential to increase scores across measures and thus their star rating. Um, in order to encourage that continued improvement across all measures, contracts with 4 and 4.5 stars for their highest rating, we propose to apply the improvement measure hold harmless provision only to contracts with 5 stars for their highest rating, beginning with the 2026 star ratings. So in other words, the hold harmless currently applies to 4, 4.5, and 5-star contracts. They are proposing to only apply to 5-star contracts to encourage those 4 and 4.5 star contracts to continue to promote improvement across their contract. There's also a proposed change to the improvement measure application. So this is mostly just a clarification of the order of operations for the hold harmless versus the HEI reward. So CMS said that they're going to determine the application of the improvement measures before they add in the HEI reward. Then when they add into that HEI reward, they'll go back and use the unrounded rating with either the improvement measures added or not. Then they round. So like I said, it's just an order of operations. They'll figure out if the improvement measure should be added or not, and then go back and add the HEI reward to the higher of those two calculations. For 2027, there are a number of changes that are proposed to the Health Equity Index. Most of these are just technical clarifications, so I'm not going to cover them in too much detail, but rather to give you a high-level flavor of the changes, and if they apply to you, I recommend that you go back and review these in more detail. So first, there were some changes to the enrollment calculations. Whether we're talking about a consolidation where two plans come together or a breakout, as we would see in the case of like a DSNP exclusively aligned program where it gets broken out from the rest of the existing contract. So whether there's a consolidation or a breakout, there are rules defining how both new and surviving contracts should be calculated, how their enrollment is calculated towards the calculation of the HEI. There was also a clarification for I-SNP contracts. I-SNPs will only need half of the measures that are required for I-SNP plans to report, not half of all of the measures that are needed to report in order to calculate for the HEI reward. So all of those technical clarifications apply only to very specific considerations such as consolidations or I-SNP contracts, but this last piece applies to all plans and their calculation of the HEI reward. So make sure you have your listening ears on for this one. CMS is proposing to add in geography as another social risk factor in the calculation of the HEI reward. So right now, the HEI reward is based on low-income subsidy, dual eligibility, and disability. So geography would be added to that list with the thought that members who live in rural areas are known to have poorer care than members that live in urban areas. Okay, on this screen, I have a number of changes that were proposed for measurement year 2027 and beyond. As I said, the further out that we get, the less that's known about those changes. So I've shared what we know at this point here on this screen. The column in the middle lists whether or not it is considered to be a substantive change. And all of these measures, all of the proposed change are substantive, except for the diabetes care blood sugar control measure. You see that one is listed as a no in that middle column. So if any of these changes were put in place, these would be considered substantive. The measure would have to come out of the star ratings program and then be brought back in again after 2 years. You'll also see that several of these measures are listed as moving to ECDS. As we know, NCQA is retiring hybrid measures, adding in a number more of these ECDS measures. And so you can see how all of these measures that are from the NCQA steward are following that momentum towards ECDS measurement. So I won't go into the changes there. You are able to read those for yourself there. This is a great takeaway slide. I will also point out that there are a few measures there, such as transitions of care, where I simply left a question mark. CMS didn't go into the specific changes that they are proposing for these measures, just that, and for example, in the case of TRC, they said they are proposing substantive changes based on expert feedback. So what those changes will be are unknown at this time. I'm sure as we get closer to the finalization of those measures, we'll learn more about the proposed changes. So as we've gone through, there are quite a number of changes that are proposed for the next several years. And it really shows you the degree to which CMS is intending to change the star ratings program. Up until now, we've really covered specific measures and specific changes that CMS is looking to do. In this section, we're going to zoom out a little bit and look at some of the bigger themes that CMS discussed in this proposed rule. In general, the proposed rule isn't about codifying changes, but rather exploring areas of interest to CMS so that they can collect their feedback. And so I'll just summarize these themes at a higher level in this section. Okay, so the first theme that CMS talked about was this move towards the universal foundation. CMS stated that they're continuing to move into that direction where they want to have that same building block approach across all of their programs so that there's a consistent core set of measurement. So my takeaway for you here is that the rest of the universal foundation measures are almost assured to be added to the star ratings program at this point. You saw that IET was already proposed and the rest are, right behind it. So if you are not doing well in any of these measures now, I recommend that you start getting the pieces in place to get your ratings up on these measures because they are as close to a sure thing as possible. A lot of plans, for example, are struggling with the social needs screening and intervention measures. So if you need to put more infrastructure in place, more data collection in place in order to do well in those measures, I definitely think it would be worth the investment to do that because these are nearly assured to be part of the program going forward. The next theme was one of simplification and refocusing of the measure set. Essentially, CMS wants to remove measures that are focused on operational performance or completion of administrative processes. These are measures, right? They're about checking a box, making sure that you have the right pieces in place and they're not outcome focused. These measures also tend to have relatively high performance across the industry, and there's not a lot of distribution between the highest and the lowest performers. So CMS wants to remove these measures, maybe continue to monitor them in other ways, such as using CAP surveys, but really focus more on measures that focus on clinical care, outcomes, and patient experience. So I thought this was a very interesting one. Conveniently, this proposed change would remove the recurring headache of TTY for CMS. So I'm sure that they would love to get rid of this measure. As I mentioned earlier, that these measures tend to be very highly rated for plans. And so my recommendation here is to model how these changes will affect your plan. Do the math path and understand what the impact will be, because you're probably going to lose a lot of highly rated measures. Will your contract rating drop once these are removed? Another thing to think about is that the relative weight of all of the other measures will increase if they take these measures out. So think about the improvement measures. They're already a 5x weight, but if you remove some of the measures, the relative weight of everything else is going to increase. So it's likely that the improvement measures themselves could possibly contribute 15% towards the overall stars pie. So it's very important to understand the impact of these measures, consider what it'll do to your contract rating, and then set your targets appropriately. You want to make sure that you're achieving significant improvement in as many measures as possible because those improvement measures could contribute so much towards your overall score. So that's a very big change that CMS is proposing here. And it's not one that they're going to take lightly. They actually ran it by their technical expert panel, and they shared the outcome of the panel's review of this proposed change in the advance notice. So their technical expert panel did not recommend making the measure set any smaller. They said, given the high stakes nature of the star ratings program, it's good to have a wide variety of measures included. They did, however, support rethinking the measures included. So they were on board with adding in more outcome-based measures that are based on evidence, such as, don't make sure that the member got an HbA1c during the year, rather make sure that it's under control. Same with blood pressure. Don't just say, are they taking a medication or did they receive a prescription for a medication? Instead, measure that a blood pressure is under control. They also suggested adding in more of those evidence-based measures, making sure that the measures are relevant and not a burden on providers, and also consider removing the gameability of measures. So I know we talk about math path all of the time, and I think in general, CMS doesn't want us to focus so much on that math, but rather on providing good care to our members. There's about a million different things that you could think of related to this, right? What measures are going away? What might they add? How could this affect my approach to stars? And it can be very overwhelming very quickly. So my takeaway from this slide is that change is inevitable, and there's always going to be new proposals, right? There's a new administration in place. There are going to be things that are going to change. We don't want to be focusing on following after the new and shiny things that change every few years. My recommendation is to focus on doing the basics well. The things that are going to set you up for long-term success are things like investing in good data connections, making sure that you have good provider relationships, making sure that you have good member experience, and that you have the members a member-centric view to give members with a well-rounded, good care. So instead of focusing on that gameability, really focus on good customer service, solid operational performance, and providing members with good, well-rounded care. So no matter what administration is in place, what rules may change, this is always a good practice that can lead to good star success. All right, let's talk about the next key dates that are coming up that you'll need to keep track of. So the information that I covered today are from the December proposed rule and the January advance notice. So after these, there was a comment period that ended on February 10th. That's already passed. So the next thing that we're waiting for at this point is the final rule itself, which will be available no later than April 7th of this year. Once that final rule is published, We'll have about 2 weeks to go through that and digest that information. And then on April 23rd, we'll be having another webinar to review those finalized changes, share that information with you, and again, share our thoughts on where STARS is headed. So we covered a lot of information today. I hope that you found this to be very insightful. And with that, I'm going to turn it back over to Cassie to wrap us up.
Thank you so much, Marge. Great information. We know these key dates and details can often be tough to keep track of, so before we close today, I have a couple of resources to share. I welcome you to scan this QR code that's on your screen right now to download Cotiviti's CMS Star Ratings calendar as a reminder of proposed and confirmed changes to the CMS Star Rating system. We keep this calendar consistently updated throughout the year, so you can bookmark this tool for an up-to-date reminder of proposed and confirmed upcoming changes to the star rating system. You might also recognize the color coding on this calendar. The check boxes Marge showed throughout today's webinar matched the colors used for proposed and confirmed changes on this calendar. So we hope you find that everything matches up and you're able to keep track either with the on-demand recording of today's webinar or the star ratings calendar. And if you need help building a strategy, Cotiviti tracks and applies all of CMS's updates to measures and weights into our Star Intelligence solution, helping our clients get ahead of anticipated changes. To learn more about the Star Intelligence solution, you can contact us at any time at answers@cotiviti.com. Next, here is a QR code to register for the other webinars in the Quality Decoded series, featuring Marge and other experts from Cotiviti's Quality and Stars team. If you haven't already, you can register for any or all of the rest of the series. We are closely monitoring the ongoing modifications and updates to the rules and guidelines set by CMS. If there is a need to modify the Quality Decoded webinar schedule, we will communicate with all registrants via email. And lastly, if you submitted any questions during Marge's presentation, your Cotiviti account team will follow up as appropriate. You can also send an email at any time to answers@cotiviti.com with additional questions or for more information. This concludes today's webinar. Thanks once again to our speaker, Marge Ciancetta. We'll be reaching out to you via email shortly with a link to the on-demand recording of the webinar. And as soon as the session ends, you'll have the opportunity to answer a short survey about your experience today. Thank you once again. I'm Cassie Yazzo, and we look forward to seeing you again soon.